Hi, my name is Emily Taylor. I'm the president and CEO of Solve ME, and I'm also the founder of the EmPOWER ME series. And I am so humbled and honored to kick off this year's EmPOWER ME session. EmPOWER ME, for those of you who might be your first time joining us, was created with one simple belief that no family should ever have to learn the hard way. So whether you've been navigating ME, CFS, and related illnesses for years, or if you're newly diagnosed and overwhelmed, you need tools, you're looking for support or community right from the start, EmPOWER ME is here to meet that need. Today's session is all about one of our most powerful and misunderstood tools that we have, pacing. Pacing isn't just about energy management. It's about reclaiming your time, your body, and your agency. It's an act of resistance in a world that pushes productivity over health, in a world that often fails to see our worth when we are forced to slow down. But in that slowing down, there is power. Pacing teaches us to listen inward, to respect our limits without shame, and to find freedom in our boundaries. And as we talk about pacing today, from the physical pacing to the cognitive pacing, from recharging our batteries to protecting our social and emotional bandwidth, I want to acknowledge that not everyone can be here with us live in this room today. One thing I am personally committed to is making sure our severe ME community is never left behind. Too often, the sickest among us are also the most invisible, too ill to participate, to speak, or sometimes even sit up. But those severe folks are central to our mission and to our movement. So today, I'm deeply honored to kick off this EmPOWER ME session with a video from Hollis Mickey, who lives with severe, very severe ME, and has graciously agreed to record her story for us. Her words remind us who we're fighting for, why we're pacing, and when pacing done right, how it can be life-saving. So with that, I'm going to have Hollis join us by video.
I'm Hollis, and I'm entirely housebound and mostly bed and couch bound. And I'm able to join in this video form today, but would otherwise be unable to participate in the live dialogue. I'm here to speak just from my own experience today, and I know that other clinical professionals on this panel will have lots of very specific and useful ideas to share about pacing. First, I want to recognize everyone who can't join us today to share their voices. The most severe cases are so often left out of research, recommendations, and community care. Pacing comes from a Latin root, which means to stretch, and I think it's helpful to recognize that so often pacing is presented as a stretching the limits of your physical capacity, operating just below an anaerobic threshold, a threshold that crossing would cause PEM. I think we need to reframe this language of stretching. Pacing is so often presented as incumbent on the patient, but pacing is really something that everyone around the patient needs to support and make possible. It's not something that can be done alone, and quite frankly, it's not fair that it's the main strategy or quote treatment that we're given. Still, it's what we have. As you can probably tell, I'm taking breaks in this video. For me, the most useful phrase has been to do less than 50% of what you think you can. So if you think you can set up for 10 minutes, sit up for less than 5. If you think you can talk to a loved one for 20 minutes, speak to them for less than 10. That being said, for many of us, it's not always something within our control. PEM or worsening of baseline may be inevitable, no matter how restrained we are. Pacing is more than a lifestyle change, it's loss. It's constantly being meta, watching your body react to anything, and it's virtually impossible to stay fully present. There's so much grief about what you can't or don't do just to get through the next hour or next minute. It's not thriving, it's surviving. And you lose part of yourself. Like any loss of a loved one, make sure that there are ways to mourn and grieve. And for me, part of pacing emotionally and not being overwhelmed by grief has meant making small moments and offering up moments of grief to mark those losses. Finally, I want to offer that we might change the language of blame. Often we say, I crashed myself, or feel frustrated or blame ourselves for exceeding a threshold. I am the biggest culprit of this, but crashing is not always predictable. In a way, I've reframed this is that my body is having an unreasonable reaction to a reasonable action. Our bodies should be able to tolerate walking to the kitchen multiple times a day. We should be able to excitedly talk to our loved ones for however long we want, or look out the window, read multiple emails. It's not my fault that doing these things would cause my body to react with a litany of symptoms. I wish I could say you could reach out to me with questions. I wish I could be there with each one of you. But I know I can't respond to your questions. The Bateman Horn Center and Solve are a great place to turn for support. We are alone together in this.
Thank you so much, Hollis, for sharing this perspective with us via video and ensuring the inclusion of the most severe in our community in this dialogue. And again, we're so grateful for all of you for taking your precious energy and spoons to join with us today. We hope you find this presentation empowering and helping you and your family never have to learn the hard way. So with that, I turn it over to our moderator, Monique Wyke from Solve ME, who is familiar to many of you, who is the leader of our advocacy program this day. Thank you so much.
Hi, everyone. So glad to be here with you. Today, I am so excited to introduce our panel of incredible experts, both from the professional side and from the lived experience side, who will walk us through the different dimensions of pacing, what it really means, how to do it well, and how to adapt it to your unique life. First, we have Todd Davenport here, who will ground us in what pacing means conceptually and practically, especially for those who are newly diagnosed. Then, Clayton Powers will share techniques for recharging faster and making the most of your limited energy. And finally, Dr. Lisa Hamilton will guide us through the social, sensory, and emotional layers of pacing, how to pace our minds, our relationships, and even our feelings. This isn't just a panel. It's a conversation about hope, strategy, and survival. So whether you're here to learn, to validate your own experiences, or to find new ways to support a loved one, I am so glad that you're here with us today. Let's begin. I'm going to hand it over to Todd.
Hello, and thank you so much for having me. Wow, I just got big all of a sudden. I feel like I'm now filling up the screen, so I'll try not to look at myself because it's a little distracting. Nice to be with you. Wonderful for Hollis to start us off, grounding us in lived experience, because ultimately people who are living with ME are why we're all here. My name is Todd. I go by he, him pronouns. I'm a professor and chair of the Department of Physical Therapy at University of the Pacific in Stockton, California, which is just east of San Francisco, far enough away we can't see the bridges. And I'm a physical therapist, so already for a lot of people, that's two strikes against me. I'm an academic. I don't live with ME, and I'm a physical therapist and exercise guy. So let me redeem myself for the remaining maybe 8 minutes that I have to speak today. I also am a volunteer scientific advisor and have been for almost 20 years to the Workwell Foundation, which is just to our west in Santa Rosa, California. And it's there that that I've been working with the group on two-day cardiopulmonary exercise testing, really trying to understand the underlying pathophysiology associated with physical activity in people with ME/CFS. So I want to start my remarks by acknowledging that ME/CFS is a complex, multi-symptom, multi-system disease process, and it's a lot of different pathophysiologies under one umbrella. It's a little like proverbially shooting fish in a barrel. You're likely, if you have a hypothesis about a system that's dysfunctional, you're likely to be correct. And I just want to sort of acknowledge my own bias up front as an exercise physiologist and physical therapist who has studied the response of the body to exercise, that I will be discussing ME/CFS through a rather narrow lens. And that narrow lens is as a bioenergetic phenomenon, unpacking a term that I heard Hollis use, which was anaerobic threshold. So we'll talk a little bit about that today and how that relates to pacing. But that's not to also fail to acknowledge or to discredit other hypotheses about the pathoetiology of the disease or other ideas that people have out there about it. And I've spent the last 20 years really trying to understand the clinical hallmark of ME/CFS, which is post-exertional malaise, which is also referred to as post-exertional neuroimmune exhaustion. And so I'd like to sort of summarize what we know about the bioenergetic pathophysiology of post-exertional malaise using an analogy. And for people who've heard me speak before, I apologize. Maybe you've heard this analogy before, and I want to credit Dr. Chris Snell, who came up with this. I was not smart enough to come up with this, but I've refined it over time and tried to add to it, and I present it to you. And that analogy is the plug-in hybrid car. Now, if you ask me much about how a plug-in hybrid car works, I wouldn't be able to tell you. So I'm not here to provide mechanical advice, but I know this much, that a plug-in hybrid car has two sources of fuel to make it go. It has a battery, and it has a gas motor. And the battery is really good for things like kind of lower level, lower speed, stop and go traffic, kind of in the city, kind of just tooling around town. And the gas motor is great for when you have to go faster on the freeway, if you're hauling people in gear. And the gas motor also can charge up the battery. And so by analogy, the battery is aerobic metabolism, really powerful, kind of takes a bit to kick in, but allows us to do a lot of things, and it charges up the other main source of metabolism that we have, which is our short-term energy system. And there's a couple of them. And so what happens now if we take our plug-in hybrid car and we make the gas motor unreliable? It doesn't really work well. Well, we lose some abilities. We lose the ability to do kind of higher capacity activities, higher loading activities, and then we also lose the ability to charge up the short-term energy system. So the concern, if you have a dysfunctional gas motor, is that you're overusing your battery. So you're overusing your short-term energy system, because your long-term energy system does not work properly. And we notice this trend that's kind of becomes accentuated or exaggerated after a prior exertion, a prior known physical exertion. So in other words, when you're experiencing an exacerbation of post-exertional malaise, if your symptoms fluctuate, and some people's don't, some people's are just sort of present all the time. And so as it turns out, our bodies are a lot like a plug-in hybrid car, and having ME/CFS is like having the gas motor not work in your plug-in hybrid car. Now, there's sort of a transition point between the exertion level where you use your short-term energy system or your battery and your long-term energy system or your gas motor. And that transition point we refer to as the anaerobic threshold. And so it's a basic way that you can kind of think about it. It's essentially sort of where the anaerobic threshold is. It's kind of a simplified explanation. The anaerobic threshold is really where your aerobic energy system stops working, and you sort of kick in all of your last-ditch metabolic efforts to run away from the saber-toothed tiger. And these are sort of at the very end of your physiological capacity. And what we notice is that people with ME/CFS have a lower ability to do that. They that that value that kind of kicks in at a time that is at a lower level of exertion and also earlier in an exercise test. So all of this is to really sort of validate the lived experience that post-exertional malaise is sort of not a phenomenon between the ears. It's not a functional disorder. It's not a psychiatric condition. It is a bioenergetic phenomenon where the body does not create and produce sufficient energy because the different substrates necessary to use so get used up and don't get replenished in the appropriate way. So I think when that gets explained in such a way, it kind of helps people sort of understand a little more about the disease. It also helps people understand the kind of the basis for pacing. So there's one more analogy that I want to introduce, and then I'll turn it over, of course, to my other panelists because I don't want to take up all our time. There's a credit card analogy that we use. So everyone's sadly familiar with credit cards, and normally the normal metabolism involves running up, exertion on your energy credit card. And, in a person who does not live with ME, who does not have ME, there's a normal kind of low interest rate to pay it back. Doesn't take very long to pay it back. Um, and so, but there tends to be a pretty high limit. So you can run up kind of a lot. And the kind of better physical condition you are in, you can run up more, pay back sooner. But in people with ME/CFS, it's like having a high interest rate, low limit credit card. So not only can you not run up very much, but it takes you a long time to pay it back. And so what we sort of come up with is this whole construct of less is more. Um, why is it? So we want to make sure that we're not exceeding that anaerobic threshold, or if cognitive triggers are more of a thing for you, not exceeding sort of that cognitive threshold, recognizing that threshold may fluctuate between days depending on prior exertion, depending on disease severity. But just overall understanding that less is more. So I'd like to turn it over to my other panelists to sort of flesh out what that less is more really means.
Thank you so much, Todd, for sharing with us. Really, really appreciate it. I am now going to hand it over to Clayton Powers to share some techniques on recharging faster and making the most of your limited energy and additional tips and tricks.
Thank you. Todd did a great job. And also, it's super helpful to have Hollis's video shared first to kind of set the tone. And then I'm just honored to be a part of this inspiring group of people and to be able to join you. I wanted to start by sharing some good news, and that's that more and more over the last few years since COVID, there's a lot more out there about the harms of graded exercise and the benefits of pacing. I was actually reading a research article this week and saw that they surveyed patients with long COVID and asked what the most helpful tips for long COVID were, and pacing was one of the top recommendations, and graded exercise was much lower it mostly caused most patients harm. And so I think the tide is turning, that healthcare professionals are more curious about how to help people pace. They're more curious about what pacing is and why it's necessary for ME/CFS and long COVID. And so the good news is there is more recognition and more healthcare providers trying to learn and trying to help. So pacing, in one way it can be defined is balancing rest and activity. So that rest, though, can be ineffective if it's not done in a way that's the analogy I use is kind of like your cell phone. If somebody's charging their phone, but they're still watching videos or doing other things on the phone, it doesn't charge as fast. It's more like slow charging. On the other hand, if you plug in your phone and maybe even turn it off, or you plug it in and you have the right charger, then it can charge a lot faster. And so we want to, as a therapist, as a physical therapist, I spend time trying to help each person with their unique needs and what helps them to recharge more effectively. And so we try to come up with a unique toolbox of strategies to help that individual to charge more effectively. And so sometimes I'll tell patients just laying down by itself may be kind of like slow charging. If you're laying down, but you're still having a conversation, or you're laying down and you're still attending to something, that might not be as effective of rest. And that's okay. Sometimes we multitask, but in order to improve that charging, to make it more effective, there are some strategies that can help to improve the amount of recovery during a rest break. One of those is, in research in individuals with ME/CFS, they've found that there's a decrease in blood flow to the head with being upright. So pacing upright activity, but also that means laying down is not only the answer, but also they found in a different study that while laying down, individuals with ME, depending on the severity, don't get that return in blood flow to the head as quickly as normal. So in most people, when you lay down, blood flow to the head normalizes within 1 minute. Whereas in the research, they showed that depending on the severity, it could take up to more than 15 minutes for that blood flow to normalize. So instead of just laying down, we want to work on things that can push that blood and improve flow back to the head. One of the things that I use often with patients is pneumatic compression boots. So they inflate and can help push blood flow more quickly back up to the head than just laying down. Elevating the legs can also be a helpful strategy. So elevating the legs above the heart, or having somebody who manually kind of pushes blood flow back up to the head by kind of providing gentle massage up the legs or the abdomen to try to improve blood flow. A lot of these things are unique to each individual, so not all of these things will work for everybody. There are patients who have intracranial hypertension or too much pressure in the head when they lay down. So adding more pressure is not going to be is likely not going to help, and may even be worse. So not all of these strategies are helpful for everybody. And that's why it's so important to work with a therapist or another healthcare provider who can understand your unique needs. Another thing that I often find with patients is after exertion, there's most of my patients have heat intolerance or become overheated, especially in the back of the neck and spine. So we'll put cold packs on the back of the head. Not usually too cold because of the extremes in temperature can be overwhelming for some people and may exacerbate the symptoms, but we'll have people lay down and kind of build their own recharging station in their house where they have cool packs, they have fluids, compression, and all these different things to help recharge more than just laying down, but using other strategies to help the body kind of get into that rest and digest um, um, that rest and digest state. So another thing that can be helpful for individuals who have more hypermobility or joint hypermobility in the hips and pelvis are joint supports. So something like an SI joint belt can provide pressure around the hips when laying down and take away some of the pain and discomfort. Other pillows or joint supports that can help the body relax more and not be spending so much energy trying to hold things together. So those are all unique things that we'll try together. And then also, as Todd mentioned, the body can get into a state of creating too much waste product or metabolites and other harmful things. And so gentle lymphatic massage on the head and neck can be tolerated and helpful for a lot of patients, but it has to be also paced because doing too much of anything like a lymphatic massage can also trigger post-exertional malaise. And so all of these strategies are unique to each person. We try to identify what is best for that person, what helps them rest and recover from a post-exertional malaise episode a little bit clear or a little bit faster so they can get back to baseline. But not all of these strategies work for everybody. And so that's why it's so important to have caregivers or other family or others who can support you in the home and who can explain to your caregiver or to your healthcare providers what's most effective for you as you also try to implement pacing. And one more thing is there's so many different types of pacing. So I mentioned pacing upright activity. So being upright drains a lot of energy. For some people, noise is the main thing that really is needing to be paced, or lights, or stress, and family relations, and other sensory inputs. And that's where we'll hear more about that in the next section. But there's so many different aspects of pacing. So it's not just laying down and trying to rest, but it involves pacing all those other sensory and emotional inputs as well. So I'll turn the time over to Lisa and we'll go from there.
Dr. Lisa Hamilton would like to welcome you to jump on. So Lisa's going to talk to us a little more about the social, sensory, and emotional layers of pacing. So how to pace our minds, relationships, and feelings.
All right. Yes, thank you. Can everybody hear me okay? Perfect. Hi, my name is Lisa. I am so honored to be here today. I'm an occupational therapist and a person with ME, CFS, and POTS from a COVID-19 infection. And there are so many things that I want to cover today. So pacing, I think one really important thing to emphasize is that it's not a one-size-fits-all term. So what pacing looks like for each person can vary greatly depending on the severity of your condition, what your daily demands are, the level of support that you have around you. All of these things are part of our pacing strategy. So Clayton had mentioned pacing upright versus horizontal activities. For some people, pacing might mean spending most of the day horizontal and having very structured, intentional rest. And for others, especially if you're someone who's balancing caregiving or parenting, maybe working or school, your opportunities to rest might be limited or unpredictable in the day-to-day. So it's important to know that that doesn't mean that pacing isn't possible. It just means it might look different, and it might not be the ideal pacing if you were to do everything textbook perfectly, and that's okay. So I really like to focus on, like we said, how everybody is different, helping people pace as best as they can within their current reality, because pacing counts even when it's maybe considered imperfect. All those small adjustments can really make a meaningful difference. Clayton had just started mention at the end of what he was saying about how pacing isn't only about the physical pacing, but it really is an all systems strategy. It includes the sensory environment, our social relationships, mental workload, even the design of our spaces within the home and in the community. And what's great about pacing is that it really can help us prevent cumulative overexertion across all domains, not just the physical domain. And this helps us to be able to maximize our quality of life within our energy envelope. So I could talk about pacing for hours and hours and hours. Unfortunately, I don't have hours and hours and hours today to tell you about it. So I'm going to give you some of my favorite practical strategies and tips that you might be able to implement into your life. So first, we can talk about sensory pacing. It can be difficult to think of how sensory and cognitive exertion can take our energy away because it's not as visible as maybe working out and sweating and the heart rate going up, but it is something that still expends lots of energy. So limiting bright lights and noise when you can. A lot of harsh fluorescent white light and blue light can be really taxing on the sensory system. So reducing that when possible. A lot of times a red light bulb can be helpful for a soft red light glow as opposed to a blue light. Having noise canceling headphones available to you or earplugs, maybe an eye mask, those can all be things that kind of help taper down that sensory input that we're getting. Another thing that is often overlooked is the things that we use in our daily life, maybe our chemicals and products within our home, or even the products that we're using on our body. Highly fragrant detergents and cleaning products, maybe very scented body lotions, even your toothpaste and mouthwash. If you have that really strong minty mouthwash, those are all very sensory stimulating chemicals. So opting for unscented or lightly scented products, maybe a gentle mouthwash that's not overwhelmingly minty, those can all be things that kind of help taper that down. Also, within your environment, there's things that can be helpful. Aside from all the compression and fluids that were mentioned earlier, those are all great and some of my favorite things. Another great component is self-care. So oftentimes, one of the first things that goes is self-care, because oftentimes we're so worried about doing the things that we have to do, must do, are non-negotiable, making sure everybody else is taken care of. But sometimes the self-care can kind of get lost in that mix. So creating a bedside self-care kit has been something that I've found personally very helpful, and I know lots of others have as well. I actually brought mine today to show you, but just a few items that you can keep at your bedside when maybe you're not able to get up to the sink. I have a no rinse facial cleanser to wipe up, a toothbrush, some floss, a little bit of lotion, some wipes here, just little things that you can use to help yourself freshen up from a horizontal position in bed so that you can feel a little bit more taken care of without having to get up and go to the sink and stand and do all of the things. There's also equipment within your home that can be helpful. So using shower chairs when you do have the energy to make it to the shower, long-handled sponges, those sorts of things to help conserve energy during your hygiene tasks. And also overall, just minimizing the need to get up often throughout your home as much as you can. So staging things and setting up what you need beside you to reduce the back and forth movement of running to this room or another room or upstairs, and trying to really set yourself up for success in that area. Within cognitive pacing, that can be one of the trickiest things to recognize. I will never forget when I was studying, it was a period when I was studying for my board exams, and I thought that I was pacing so well. I was being horizontal, and I was laying down and resting, but I was studying all day long, just reading and reading and reading. And I was having crash after crash after crash, and I just couldn't figure out what was going on. But that cognitive exertion is a huge component. And for some people, cognitive exertion can trigger PEM even worse than maybe physical exertion. Everybody's a little bit different there. So cognitive pacing fatigues are also very important. And that's not just reading or writing emails, but also those conversations that you have with people, social interactions. All of these things are part of a cognitive load. So a few tips, external memory aids. It sounds simple, but sticky notes and to-do lists, writing down the things that you need to remember or achieve when you initially have that thought prevents you from having to go back into your brain and think about what it is that you were trying to remember earlier. So sometimes I'll just dictate to my phone right when I have a thought, so it adds to my list, and that takes off the burden of having to go back and remember that later. Taking little cognitive rest breaks. I know Hollis had mentioned in her video that she was taking pauses when she was speaking, taking the time, even if you're at work or doing a lot in school, just taking the time to sit down, close your eyes. I like to call it micro pacing, but even if you're not able to lay down completely and reduce all the sensory stimulation in your environment, sitting, taking a moment, closing your eyes, throwing on those headphones if you can, and just allowing yourself to take a few minutes to regulate can also be very helpful. I could go on forever about these things, but we do have limited time today. But these are just a few strategies. I just really want to thank every single person that has been a part of Advocacy Week, whether you're someone living with ME/CFS or a caregiver or healthcare provider or just someone who's interested in learning. I just want everybody to remember, if you take one thing away, that pacing in itself is a part of advocacy. It's you saying that my health matters, my limits matter, and that you're refusing to sacrifice yourself to be more palatable to a system that may not have been built with you in mind. So thank you all for being here, and I'll turn it back to Monique.
Thank you so much, Lisa. And thank you to all our panelists today. What we are actually going to go ahead and do now is bring all of our panelists to the screen. So Carmen, if you want to help us pin everyone. So we are going to go into a time of question and answer. I'm seeing some amazing questions in the chat, and I know that not everyone watching online is able to see the chat. So I would love for us to actually bring some of those conversations to the broader group. I'm going to start actually with a great question that came through, which was just asking a little bit about, can you explain rolling PEM, so post-exertional malaise on a rolling basis? And Todd, it looked like you had a great response on that one.
Yeah, thank you. I mean, I'll let the audience decide if it's great, but this is sort of the way that I've come to think about rolling PEM, because we talk about PEM as this thing that comes and goes, that fluctuates up and down, and that's just not the experience for a lot of people. And so it can be really frustrating to hear this explanation of PEM or having it defined as fluctuating signs and symptoms when that's not your reality. Um, I think about post-exertional malaise as waves in the ocean, where the crest of the wave is an increase in signs, symptoms, and disablement. And if you have waves that crash on the shore more frequently, then the water level is going to go up. And so it's just going to look like that base level of water is higher. And so I think of I think I don't I think of this whole idea of post-exertional malaise as coming and going, and rolling post-exertional malaise as being very compatible, where rolling post-exertional malaise is just the additive effects of multiple intersecting waves or exacerbations of post-exertional malaise. And I think it's reflective of disease activity, and I think it's also reflective of disease severity with rolling post-exertional malaise. So one of the things that I've noted, and I don't know if this lines up with folks' lived experience, but of course I'm just sort of a traveler here, a guest here. One of the things that I've noticed is that as disease activity recedes, then post-exertional malaise takes on more of a fluctuating character that's more responsive to specific triggers rather than just sort of present all the time.
Thank you so much for sharing that. I also wanted to open it up to see, Clayton or Lisa, did you have anything to add on that piece?
I think that was fantastic. I was just reading the chat, and Todd, you've been very busy in the chat. This is great. There's so many amazing questions. My own personal experience with rolling PEM was actually one of the reasons that it took me so long to figure out what was going on, because it often wasn't a really discernible crash at first. It was this gradual decline in functional capacity almost, or overall health, that kept accumulating over time until my body almost just shut down for a period of time. And I was housebound for a couple months, and all that to say, it really can sneak up on you. And when it's not something that you're aware of, and maybe you haven't learned about pacing, it can continue to get worse, and then it can be a lot harder to recover. So, and start to kind of get some of those things back and get out of that crash period. So I think that was all really, really helpful. Thanks.
Clayton, anything else from your end?
No, I think that covered the rolling pin.
Okay, wonderful. Okay, so another question that I am seeing is just kind of asking, why is it that people end up getting PEM 2 to 3 days after the exertion? And are there theories behind that, or metaphors that kind of help to explain that a little bit? And I will open that up to anyone on the panel who would like to answer.
I think Todd probably has the most scientifically backed answer for this one.
I'm holding back on the science because I don't know who sort of comes with what knowledge and experience, but I will say that there's sort of this process by which the body creates energy by burning fats and sugars, and it's a multi-step chemical process that basically every healthcare practitioner learns like in the first semester of their training program, and everyone wants to forget. But ironically, I've made an entire career of talking about the one thing everyone wants to forget because it's so important. Um, and so I think there's a rate at which these substrates get used up and don't get appropriately replenished. And so there's some lag time in the system. And of course, people are probably listening and going, well, that's all very elegant when you're talking about more physical manifestations of PEM. What about cognitive? What about emotional? And just remembering that every cell in the body has to metabolize something in order to function. And if you look at a survey of body cells, I don't think we've found one yet in people living with ME that doesn't have bioenergetic problems. Immune cells are de-energized, neurons are de-energized, skeletal muscle cells, vascular endothelium. They all have energy deficits, energy deficits in the blood. And so I really do think it has to do with sort of using up the substrates and the rate at which that they become replenished.
I'll just add a yes and to that. One thing that I've noticed in my family's journey with my mother's post-exertional malaise is that for her, at least, we can tell she's starting to really decline when she gets that last ditch energy spike, when her body's like in emergency mode, and then she sort of goes a little bit bouncy, and then we're like, oh Lord, you're gonna crash soon. So that's a pattern that I know other folks have noticed as well. So that's a good sort of point to be especially aware if you're feeling like you're declining and then you get that sudden energy pump. That's then even more time to rest. Don't let that energy pump fool you. That's the last emergency klaxon before you're really going to crash. So that's something that we've learned to kind of keep an eye out for in our family journey, and hopefully that'll be helpful with yours as well.
It's a really good observation. It's that whole tired and wired phenomenon. So you don't just get the crash, but you get the wired before the crash, or sometimes wired early in the crash, and that really has to do with your fight, flight, or freeze nervous system, which is sort of a layer that we haven't discussed, but is also dysfunctional in people with ME. And so your fight, flight, or freeze nervous system is in charge of keeping you from being eaten by the saber-toothed tiger, or I explain it keeps you from becoming a meal, or it may get you a meal back in our former days as hunters and gatherers. But really it's on when it shouldn't be, and it's off when it should be. So it's inappropriately dysfunctional in both cases. But yes, absolutely, that tired wired phenomenon is a thing, and is something to watch out for. It's a great comment, Emily.
If I can answer one question real quick. One of the questions is, how do I find a physical therapist that understands ME/CFS? And honestly, that is really hard, because there are Facebook groups that have been created of PTs who understand ME/CFS and who can help. But if you just go to a general physical therapist, they're likely going to push you to exercise and do more and just won't understand it. And I've actually seen OTs being more helpful for a lot of patients. We have physical therapists like Todd and I who spend a lot of time with patients with ME/CFS and help, but OTs can also be an extremely valuable type of provider to go to. But yeah, screening beforehand, so you don't get pushed to do those things that will just make things worse. So we have Facebook groups and things that we try to share resources with the physical therapists and education with them, but it's hard to know and vet different people. So it's hard to make a recommendation specifically unless we know them.
And just to jump in, interview your PT if you can before you make the journey. It's worth the effort. It's worth the spoons. Ask them about post-exertional malaise, and if they characterize ME/CFS as being a little tired and nothing that a little exercise can't fix, then you know to run in the other direction. So, it's okay to use your good sense. Now, I do know that we have folks joining from places that there is not that flexibility to choose your providers or choose your services. And so I still advocate for folks in more organized healthcare systems than the US to still try and interview your provider, so at least you know what to expect from them.
And also on the topic of that, it is sometimes a trial and error process. It's okay to go to one PT or one OT, and if they start saying things that are raising those alarm bells and those red flags, you can stop service with them and find someone different. It's not always going to be the first one and done. It's similar to finding a medical provider who understands this. And oftentimes, even finding maybe an OT or PT that has somewhat of a baseline understanding, but has that desire and willingness to learn and kind of work with you is also very important. You know, not everybody's going to be an expert on this topic because you don't really learn about it in school, but somebody that is at least willing to learn and work alongside you can go a long way.
Thank you all for sharing. I am curious to hear if there are some specific questions that you think would be helpful to ask in kind of a pre-interview with either OTs or PTs. So, Clayton, maybe we can start with you.
Yeah. First of all, asking if they know what ME/CFS is or have worked with other individuals who have ME. If they don't, then asking how willing they are to learn and change and try to help. Because I think the curiosity and willingness to be open and try something that's maybe outside their box is really how I got into this as well. It was hearing people and listening and saying, okay, well, I'm going to listen what you want and how can I help you best? And that's really key is their willingness, to change. If they already have a protocol or something that they want to push, then they're not going to be very willing to be open to helping. So that willingness to try and learn and that curiosity is really important.
And also sometimes it can be dicey because just because someone understands one condition does not at all mean they'll understand ME/CFS, but there sometimes is a bigger bank of people that may have worked with EDS or some form of dysautonomia or, you know, some of those other chronic conditions that might have energy limiting components. And it's also different because the way that the protocol for somebody who has POTS alone is completely different from the protocol you would give to somebody that maybe has ME/CFS and POTS, but at least someone that maybe works in a space or with a population that they might have heard those buzzwords or have some sort of baseline background knowledge might be good, maybe.
Absolutely. I also wanted to ask for some of those who may be more newly diagnosed or new to the community. Lisa, do you actually want to just talk to us a little bit about the difference between what an OT would address versus the difference in what a PT would address?
Sure, yeah, and it depends on the provider because there is such an overlap. I think often people really try to stick like OT and PT in these boxes and get really offended when we step on each other's toes as a profession. But I think there is so much that we can kind of collaborate on because a lot of what Clayton discussed earlier that he would help people with is also maybe things that I think I would help people with. But in general, I think OT specifically, if you're not super familiar, occupational therapy, the occupation does not refer to finding jobs. It is, the occupations are anything that you would do throughout a typical day. So those activities, self-care, getting dressed, but also going to work, driving, anything that you do. And we try to help restore function as best as we can within those things. And, you know, in this condition, obviously, a lot of times the way that we do that is through pacing and strategies and maybe adaptive equipment. So that's what we look at often. A lot of it is education and really both PT and OT, I think, are very holistic professions that look at the whole person. It's not just this is the diagnosis, this is what medicine we give it, or, you know, not saying that all physicians are like that, but it's a really whole person. What does your life look like? What are your roles in life? Are you a mother or father? Are you a sibling, a boss? What are those things that you do? And how can we help you best show up for those roles? So it really is a whole person centered and very individualized based on what needs are.
And I'm also seeing a link in the chat just about the overlap between OT and PT that Clayton has been able to share. Clayton, do you want to add a little bit from the PT side of things?
Yeah, so physical therapists generally are, in general, we're focused more on the physical, so movement. Our profession's really focused on movement, being movement specialists, so exercise, hands-on treatments and things to help. There are a lot of different types of physical therapy therapists and occupational therapists. So there's therapists that focus on dizziness, or concussion, or other neurologic conditions, or pelvic floor issues, or just your general orthopedic therapists focus on neck pain, back pain, things like that. And so same with OT, there's a lot of these subspecialties, and we tried to describe somewhat of the overlap in PT, OT, and speech therapy in this document I shared. It hopefully is helpful, but what we tried to do is just kind of show that there is a lot of overlap between PT and OT. When I've presented to some of the neurologically trained physical therapists and tell them what I do with ME CFS and long COVID, they say, that sounds more like OT. And some PTs go, I don't want to do that. That sounds more like OT. And so there is some overlap, but it's really about meeting the patient where they're at and individualizing care. That's the most important aspect. It doesn't really matter it's more about, does the provider actually try to individualize it to you? And that's why I mentioned during my section so much about the unique needs of each person, because it is so variable with each person. It's not a protocol or anything that I follow. It's I listen and try to help each person with their unique challenges.
Thank you for that. All right, so we are coming up to the top of the hour. I wanted to say thank you so much to each of our panelists for joining us and sharing your wisdom and experience today. It has been so amazing to hear from you, and also just to see your responses to everyone in the chat. I wanted to let you all know that what we're going to do now is take a 30-minute break so that everyone has a chance to recharge, take a little snack break, have a cup of tea or coffee, and then we will join back on the same Zoom link in half an hour, and we're going to have just a community discussion forum. So the first forum is going to be about pacing in public. And so knowing your rights when you are needing to pace in public, we'll be discussing that together. And then we will have a second forum this afternoon about pacing in private. So focused on prioritizing, planning, and the art of asking. So thank you all so much for joining us for the main session. We will see you back here if you'd like to join the conversation in half an hour. And thank you so much to all of our panelists.